didactic lecture is on FAST, Focused Assessment with Sonography in Trauma. A few points about the didactic lectures. Remember, hands-on instruction is better explained in the bedside videos. The reading material is important to cover aspects that are not discussed in this lecture portion, but that are important for your knowledge base. It's important to mix hands-on active learning with the reading and didactic material to best learn the ultrasound application. FAST was first used in Europe in the 1970s. ATLS adopted it since 1997 and was later incorporated into surgery and emergency medicine residency curriculums. The objective is to detect free fluid in the pericardium and intraperitoneal setting in the setting of trauma. It's a non-invasive way. Its alternatives include CAT scan, diagnostic peritoneal lavage, going straight to the operating room, or observation. But ultrasound has a higher specificity for therapeutic laparotomy than diagnostic peritoneal lavage. Probably a combination algorithmic approach seems the best. The FAST and EFAST, which is extended FAST, is the regular FAST exam with an extended pleural and thoracic assessment for fluid in the thoracic space. FAST was coined at an international consensus conference in 1996 to describe an integrated, goal-directed bedside examination to detect fluid. FAST detects fluid as low as 100 mils, but commonly cited as 250 to 620 mils. The history of FAST has changed from a system-based approach to a problem-based approach, which is also being incorporated in many other areas of ultrasound. In the case of FAST, it used to be called Focused Abdominal Sonography in Trauma, and later was changed to a problem-based approach called Focused Assessment with Sonography in Trauma, with trauma being the problem. Just like any other point-of-care bedside ultrasound, we have to have our focused questions. The first questions we have: is there free fluid in the abdomen? Is there free fluid in the pericardium? And the extended FAST adds: is there fluid in the thorax? And is there fluid in is there a pneumothorax? A few points about the anatomy. There's a right pericolic gutter, which goes from Morrison's pouch to the pelvis. There's a left pericolic gutter. It's not as deep as the right, and phrenocollar ligaments typically blocks fluid movement. Morrison's pouch, which is the hepatorenal recess, is the space between Glisson's capsule on the liver and the fascia of the kidney. The splenorenal recess, which is between the spleen and the kidney, and the rectovesical pouch, which is the pocket formed by the reflection of the peritoneum from the rectum to the bladder, which is called the pouch of Douglas in the female. The type of probe you use can be either the phased array 5 megahertz cardiac probe or abdominal probes, which have a bigger footprint and makes it easier to view some of the structures, but also makes it easier for the ribs to cause artifact. As you can see the picture on the right of the screen, there are 4 typical views for FAST: the hepatorenal, the splenorenal, the subcostal, and the bladder. So the first view is the right upper quadrant. As you can see in this picture, the normal view of the right upper quadrant should have a kidney, a liver, and a diaphragm. Once you see the picture on the left and correlate to the anatomy on the right, it becomes obvious the area that we're looking at is between the kidney and the liver. On the bottom right, you see free fluid in the Morrison's pouch, and in the next few slides, I'll show you more examples. Here's some still images with examples of liver, kidney, and free fluid between the space. Here's another example. The depth is a little bit off, but you can see the kidney where it's marked. You can see right above it, there's an anechoic area or sliver of fluid, and then above that you see the liver. Over here again, you see kidney. You see as the patient's taking a breath, you can see the liver and you can see the fluid between the two spaces. Again, over here you see the kidney. I've marked up the diaphragm, which is the hyperechoic line. You can see the liver and the fluid between the kidney and the liver. Here's another picture of a right upper quadrant where you see a kidney. You actually see free fluid and pleural fluid. And this illustrates the point that I will make in future slides, which is one of the most important things is to be able to identify the diaphragm. Being able to identify the diaphragm will enable you to be able to see the difference between free fluid in the abdomen and free fluid in the lung space. This can be very important when assessing for pleural fluid as well as patients with cirrhosis. Now back to the left upper quadrant. Typically, what I tell students is that left upper quadrant is more posterior and more superior than the right upper quadrant. The views are similar, where you can see the kidney, the spleen, the diaphragm, and what you're looking for is fluid between the spleen and the kidney, just like you did on the right upper quadrant. Here you see some pictures, some still images. On this side, sometimes it's not as easy, since the patients that have this have ruptured spleens and are hard to see the anatomical borders. The suprapubic or bladder area will show the bladder, the rectum, and what you're looking for is the space between the two, and you're looking for anechoic region, which can also be indicative of free fluid in the abdomen. Here you see some areas in the suprapubic which are positive for free fluid. The next place we're going to look is the heart. The heart, you can actually look at the subcostal view, but you may also need to look at the peristernal views in patients who are obese or who have abdominal trauma, or who may not be easy to view in the subcostal region. There are other didactic lectures on each of these individual applications, which you can refer to for the appropriate labeling and knowing best way to get the views. But I wanted to show you some abnormal patients with abnormal findings. This is the peristernal long view, where you can actually see pleural fluid, pericardial fluid. Pericardial fluid is important because once you see that in the appropriate trauma patient, you have to consider that there could be injury to the heart. Typically, pericardial fluid goes anterior to the descending artery, and pleural fluid goes posterior to the descending aorta. Here's another slide showing a peristernal long view with pericardial fluid. But what's more important to us with the pericardial effusion, is there tamponade or not? The hallmark is right ventricular free wall inversion, which is best recognized during diastole. The right atrial inversion during systole is also more common and an early finding due to the lower pressures. You also can have increased respiratory variation of the mitral and aortic inflow velocities, although we don't routinely measure those. And a dilated inferior vena cava with decreased inspiratory collapse can also indicate tamponade. Here's another case where you have pericardial fluid. it's kind of difficult to evaluate the right ventricular space in this picture. In this one, it's a little bit easier. Again, you see the pericardial fluid. This is a peristernal long view. And you can see the right ventricular weak wall collapsing during different phases of the cardiac cycle. Now, what would be more worrisome is if the right ventricle was totally collapsed and the pericardial effusion was larger. So now that we talked a little bit about FAST, let's talk a little about EFAST, which is extended FAST. If you do find fluid, move up 1 or 2 costal spaces. The lungs sometimes can be seen floating in pleural fluid. The sensitivity and specificity in detecting pneumothorax are very high in the emergency department, and you can detect 20 mils of pleural fluid versus supine chest x-ray, which needs 175 mils. The head slightly elevated can help accumulate fluid just above the diaphragm. Here's a picture where you have identified pleural fluid. One other thing that you should realize is that sometimes you see layering in this effusion, which is called the hematocrit sign, and that can be seen in hemothoraces. So let's talk a little bit about ultrasound for pneumothorax in the trauma setting. It was first described in a horse in 1986. In a normal lung, the visceral and parietal pleura are closely associated, and ultrasound shows a shimmering or sliding at the pleural interface during respiration. Absent of this can indicate a pneumothorax, although many other conditions can cause absence of lung sliding. In trauma, ultrasound was shown to be more than twice as sensitive for detecting occult pneumothoraces with similarly high specificities. Comet tells are ultrasound artifacts that arise when ultrasound encounters a small air-fluid interface and can sometimes also be seen. So the ultrasound relies on the fact that free air is lighter than normal aerated lung tissue and it accumulates in non-dependent areas of the thoracic cavity. Again, multiple studies show that ultrasound to be more sensitive than supine chest radiography. So again, the patient is supine. It's better to use the high-frequency linear array or vascular probe. The mid-clavicular line at the 3rd to 5th intercostal space to identify the pleural line, but you can look at several intercostal spaces going laterally towards the mid-axillary line. The lung point is an area where the pneumothorax interfaces with a chest wall, and you can sometimes see this as one side of the pleural line does not slide and the other part does slide. You can also graphically use the M mode, although with newer machines and saving techniques, we actually just save the clips, so M modes are less useful now. You can actually see 2 different things that you may hear from other educators. It's called a beach sign or a barcode sign. So if you put the M mode on the pleural line, you will see in a patient who has lung sliding a 6-second clip which shows waves or a beach seashore sign. If there is no sliding, then the same maneuver will result in a barcode or stratosphere sign, which you see on the bottom right. But more importantly for us is to just visualize the lung sliding. In today's world, we can actually save these clips and view the clip, so we much prefer saving clips rather than still images. Although some facilities you may still have to save M mode to show someone a 6-second clip. In this clip, you see lung sliding as the patient is breathing. The pleural line is a bright line between the thoracic wall and the aerated lung tissue beneath. It's usually the first bright white line you see 1 to 1.5 centimeters below the rib shadows. Please review the didactic lectures in the basic lung module if you are confused on this aspect. Here is another image of thoracic ultrasound with a pleural line without lung sliding. As the patient is taking a deep breath, you do not see the lung moving, the pleural line moving. The optimal depth to evaluate this is 3 to 7 centimeters. Although this image is done at 7 centimeters, I recommend you, if you're trying to decipher, to do this at 3 to 5 centimeters, or if you're trying to show students, that to do it at 3 to 5 centimeters so it's easier to be seen. So back to our focus questions. Is there free fluid in the abdomen? So again, you look at the right upper, left upper, suprapubic areas for free fluid. Is there fluid in the pericardium? You can either look at subcostal or peristernal views, although subcostal is preferred. Sometimes you may have to do peristernal. The extended fast, is there fluid in the thorax, is you move your probe just a few centimeters up from the right upper and left upper quadrant original views, and you can see the diaphragm and fluid more cephalad to that. And the last is there a pneumothorax, which you can identify by identifying absence of lung sliding in the appropriate trauma setting. And that's it.